A diabetic in hospital, it's no longer A1c that we are looking at. In an IP patient with diabetics, you need a different lens. HbA1c talked about the past. To the present, you need timed blood sugars. The first and foremost priority is avoid hypoglycemia. Hypoglycemia is more dangerous than transient hyperglycemia, especially in young patients, because it kills, and most of the time it is iatrogenic. There are a certain group of people who are at high risk of hypoglycemia. The unconscious patient, the elderly patient, the patient with a poor intake, patient having comorbid CKD, CLD. Avoid hypoglycemia at any risk for these patients. The second priority is when steroids are given, there is bound to be post-steroid hyperglycemia. A1c fails to capture this. So anticipate hyperglycemia, measure it, correct it with insulin. The third one is avoid swings in blood sugars. Two people with same sugars might have different hospital outcome just because one person has got a high swing in blood sugars, 70 in the morning, 300 in the afternoon. This patient is not going to fare well, especially if he is in the ICU, has increased mortality and morbidity. So avoid dangerous swings in blood sugars. And last but not the least is stress and acute illness can produce hyperglycemia even when the patient is not a diabetic. So these are contexts in which you need to give insulin to control hyperglycemia even when the patient is not diabetic. So at any cost, avoid hypoglycemia, avoid swings in blood sugar, anticipate steroid-induced hyperglycemia, treat the blood sugar with concurrent illness. He may not be a diabetic at all.